So Sachin, some years ago, made a comment that the dimension of the right ventricle above 22 millimeters when the Melody valve was in vogue was not going to be applicable to large size right ventricular outflow tracts. But I guess necessity is always the mother of invention, and with the advent of or the availability of the Edwards valve, which goes up to 29 millimeters in diameter, there had been a slew of increased experiences with the application of this off-the-shelf valve in patients with large right ventricular outflow tracts within some limitations. And I think one of the earlier studies was Demkow's work in 2013. And just to highlight some of the observations with these off-the-shelf valves, their experience even up to 2018 is that you can use this up to 32 millimeter diameter outflow tracts. Once you size the outflow tract with a low pressure balloon, I guess the tip of sizing the outflow tract is that not just putting the balloon in the RVOT or in the main pulmonary artery, but many people will augment the analysis by implanting a second catheter in the right ventricle and doing an angiogram to assure that the balloon is fully inflated, particularly if you don't see a waist. There's the issue of stenting. There's some experience of using the SAPIEN valve in the large outflow tract in the absence of stenting, particularly from the UCLA group. Of course, the greatest experience has been with the SAPIEN 29 and the SAPIEN 329. However, the challenge that we face in adult congenital lesions and in adolescents with congenital heart disease is that the majority of patients after Fallot's repair have very bizarre, wide aneurysmal outflow tracts which are not available or don't accommodate these off-the-shelf valves. And I'm sure that many of you have seen the slide of the anomalies of the right ventricular outflow tract where the patients with conduits where the Melody valve and the SAPIEN valve have been used fairly extensively, but it's only about a quarter of the population. 3/4 of the population actually are individuals that require or have right ventricular outflow tract patches or dilated main pulmonary arteries these valves, the Melody valve and the larger SAPIEN valve, will not be effective. So what valves are out there? Well, this is just a smattering of what are the possible valves, and what I'll talk about a few of these in detail. The Harmony valve, which is being evaluated by Medtronic, the Altera implant, which I'll detail for you by Edwards, and the Venous P valve, which is undergoing a CE trial in Europe right now. So the Harmony valve, and the Harmony valve has undergone an early feasibility study started about 3 years ago. The Harmony valve is a Dacron sleeve with nitinol supports. It's a self-expanding technology with the valve sewn inside the implant. It's delivered with a 25 French device and very similar to the release from like a AAA graft. So you unscrew it for the implantation. And for the early feasibility study, one size was available, and that was a size where the distal end was 33 millimeters and the proximal end was 42 millimeters. And that has some impact on the choice of the patients, and I'll detail what that means in a moment. So this is just a close-up view of the Harmony valve and the way the valve is sewn in to the Dacron sleeve. So how does one assess the size of the outflow tract that these valves will be used? And the most useful is a dynamic 4D CT scan. And this is an example that's acquired on the one of the dual source low dose beams, which allows you to have a very short acquisition time, temporal resolution, so you can get systole and diastole. And the thing to focus on is the dynamic change in the main pulmonary artery and branch pulmonary arteries at the different points in the cardiac cycle, which has significant impact on your choice of a device. So CT scans are done. Many people will make SLA models in systole and diastole. This is just an example of the two different phases. And in this case, this was a Harmony implant where you can do a virtual implant, if you will, on where you think the device will sit during implantation. But the real assessment of the type of device and whether it's going to sit appropriately in the outflow tract is the engineering assessment. And most of the studies are looking at perimeter data. So what is done is that the perimeter at various portions of the outflow tract are measured on the CT scan during the various phases of the cardiac cycle. And this line here is the Harmony valve, completely uncompressed. There's no interference. So that's what the valve would look like, sitting in air, if you will. And this is the profile of the valve as there's a change in the diameter or the perimeter of the main pulmonary or the outflow tract at various levels of the outflow tract. And so what you're seeing here, and this is during ventricular diastole. So during ventricular diastole, the main pulmonary artery is small, right? And the outflow tract here gets larger. So you have, this is the compression of the device during diastole, and this is the compression of the device during ventricular systole. So during systole, the main pulmonary artery, or this area of the outflow tract, enlarges. So you see the perimeter is larger, and that's the compression that you have of the device that you've implanted. So it becomes important to understand the various phases of systole, because these devices don't have hooks in them, they're not sewn in. They are implanted and stabilized by compression of the implant in the outflow tract. So this is an example of a patient with one of the Harmony implants from the early feasibility study. And in the purple, I think that's purple, that's during ventricular systole, and in the blue is ventricular diastole. And you can see the difference in the compression of the device during various different phases of the cardiac cycle along its length. And then another assessment, and I'll get back to the perimeter plots in a moment, another assessment is the virtual implant of the device inside the CT scan images, and you can get a notion of what kind of compression there'll be at different phases of at the two extremes of the cardiac cycle. But the, must be the Edwards people involved now. There we go. So this is an example of the Harmony implant from one of the studies that we had done. I think this was done with Mark and Eric on one of our patients at TGH and Sick Kids. So that's the implant of the device in one of the models, and this is the actual implant in the patient. And you can see how it's unscrewed for the implantation, and there's monitoring, a second monitoring catheter to make sure that we're in the right location. So the early feasibility study for the Harmony study was finished 4 years ago, began in 2012, and is now into the pivotal study. And these are the units that are involved in the pivotal study, and we're fortunate to participate in that study as well at the Toronto General Hospital with Mark, Eric, and myself. Now, there was a problem with the device, not so much the efficacy of its implant, but the problem was the size, because it wasn't one size fits all. That was the only size device that was available, so we had to find patients to fit that device. And we actually screened about 300 patients between the 3 centers for the early feasibility study. Of the 300 patients that we screened, screening with MR and CT scan, we thought that 67 of them would be appropriate. Of those 67 that signed the consent form, 46 dropped out because they were inappropriate size. So this was that size that I showed you, where the distal end was 33 millimeters, the proximal end was 43. So we're dealing with a population which has very large right ventricular outflow tracts, and this is just the follow-up data. We have now 3-year follow-up data, and I can share with you some of that information in a moment. This is data from the pivotal study. This is the most recent implant data from last week, and as you can see, they've screened 150 patients. Of those 150, only 12 of them have been implanted because 91 had to drop out because of the assessment, and 26 were exited by the vote. So there have only been 12 implants in the pivotal study. Why is that? Because they're stuck with that original device. The good news is at the end of this year, there's going to be a new device called the Harmony 25. The Harmony 25 device, and this is a photograph that you can't remember because they're going to kill me that I showed this, but this is the new Harmony 25, and the PA end is 49 millimeters in diameter, and the RV end is 52 millimeters, and it's a little bit shorter. Yeah, well, that's okay.
It's 100% secure because it's going to be on the web. It's going to be on the web in 2
Look,
weeks.
they sent it to me. They sent it to me. What the hell?
Yeah.
And the other thing is that it's a 25 millimeter diameter valve as opposed to a 22 millimeter valve. It's okay. It doesn't matter. They'll kill you anyhow. So this is the data on the 2-year study from the early feasibility study, and you can see that the degree of pulmonary regurgitation in the original device is fairly constant, with the elimination of the regurgitation. Paravalvular leak rate is low, and the mean aortic, this is Doppler echo gradients, slow increase for a variety of different reasons that we're assessing with follow-up CT scans in this population from the feasibility study. So I want to just jump a little bit towards the Altera device, which is also now in an early feasibility study. And this is a very interesting concept. This is actually just a stent. It's supposed to be a modular 2-phase implant where you implant the stent and then you implant the valve. And this is designed for the Sapien 3 29 millimeter implant. So it's really what they call an adaptive pre-stent. This is now finished the early feasibility study. I think they've done their 15 implants. And of the 15 implants, they've done the second stage all at the same sitting. So there had been a controversy, not a controversy, that's not right, but some concern as you put the implant in that the commander system is a little rough. It might be difficult to implant, but apparently once this gets into the outflow tract in the appropriate size patient, it's very difficult to knock out during manipulation. So this is the data on the size. The diameter is about 40 millimeters on the 2 ends, a 48 millimeter length, so it's almost 5 centimeters. And the Sapien valve would then fit in like that. It sort of looks like that. And this is just an example of some pictures from how it's implanted. It's, again, it's self-expanding with a sleeve that comes out. It has a very interesting delivery system, which Mark, Eric, and I designed because we went to Irvine and did the original delivery system. We broke it, so they had to redesign it. Very typical for us to don't show us anything.
We busted it.
We busted it.
In the animal.
Yeah, in an animal. So, yeah, so they redesigned it. So it's just a thumb screw implant, and again, it's self-expanding. As I mentioned, Evan Zahn is the national PI for this. There's four units, and they've just finished the EFS study on this. And so we're looking forward to the multi-center trial, which hopefully will begin towards the end of the year. Now, the venous P valve system is a implant that was designed in China. It's also a self-expanding nitinol stent with a porcine valve, and it's a little bit different from the other implants. This is more like a core valve concept, where it actually takes up the entire space of the right ventricular outflow tract. You know, Z has had experience with this. The international PI, I think Shaq is the international PI, isn't he?
No, I'm the global PI.
You're the global.
CE.
He told me he was from the galaxy.
No.
Yeah. he said with the universe.
No.
But we know what Shaq likes to over-exaggerate a little.
Yeah, he swore to me he was from the galaxy. Anyhow, so somebody's the PI from someplace.
The Galaxy PI?
The galaxy PI.
Yeah,
Yeah. So this design comes in a variety of shapes and sizes. Very much different from the concept of the Harmony valve or the Altera pre-stent. It's a self-expanding nitinol, and this is the PA end, which opens up into the confluence. And and this is sort of what it looks like with doing at implantation. And they also have one that doesn't have a flare, that has more of an appearance of a melody valve. It comes in a variety of different sizes. So you would take your patient, you do the assessment, you can either balloon size it, do the CT scan, and then you order the device, and they'll have it customized for you. And there's a big long chart that comes with a variety of different combinations that are available. I think 35 millimeter main pulmonary is the largest, or 34. That
Diameter or
diameter.
diameter, the largest is 36.
36, yeah, well, I'll show you why this is an exciting implant. And this is sort of the sizing that one does, and this is the virtual implant of an example of one of the patients that underwent the study. And Shaq, he's just the PI for the EU now. He's losing his status here.
Leo, I thought we were the PIs for that study.
Yeah, I
What?
thought.
Yeah, we're not the PIs?
No.
Okay.
There's another name that they use for that. This is an implant that Shaq performed, and you can see this is, to my eye, a relatively stiff device, hard to get in, but apparently it works in these very large outflow tracts, and the people who have used it, and we've got an experienced operator, have found that it's been very effective. This is data, again, from the EU PI, who told me this is through 2017, the first 45 implants. The mean age was around 23, but now there's a variety of centers. I guess this is the international group.
So he
Yes.
does not even have cutout on it.
Well, it's an old slide. What can I say?
Very well.
Yeah.
You should have called me for slides.
Well, I knew you were going to be here, and you'd say something. So, I mean, your shyness is not one of your.
We're gonna
Not in your profile.
We're gonna put all of Ziad's slides on his laptop up later from his laptop. All the slides on Twitter.
And a picture of Lee and Ziad coming to blows.
Exactly.
This is just a simple talk. Anyhow, so this is data again from that simple study. What can I say? It works. RV volumes go down.
Let's de-escalate this a little bit.
RV volumes go down, the ejection fractions go up, and the degree of regurgitation diminishes. So it works very well. The CE studies in progress started a year ago. I guess it's a year and a half ago now. Actually, Shaq was telling me that it's almost finished. I should increase my horizons of informants, apparently, about the outcomes of these studies. And that's sort of the plan for the CE study, or the multi-center trial with the enrollment criteria. The last valve I want to talk about, and very briefly, is another valve that's made in China. It's also very familiar in design. Again, a self-expanding implant, a nitinol frame. It's a porcine pericardial valve, and it comes in 5-dimensional implants. It has an 18 French delivery system, and as you can see from here, it looks very similar to many of the other types of implants. So there's a number of designs that are assessed to address the dynamic nature of the various anatomies of the right ventricular outflow tract. All tested implants so far appear effective. And there's no single device that appears to address all morphologies. So it's something that we should be aware of when we pick the patients for this study. Thank you very much.
Okay, let's take a few questions.
So, Lee, with the engineering testing and all the other things, other than a really pretty picture that shows up in a talk, the SLA models right now, how are you using those? And is it beneficial for training of how to put the first one in? And now that you've done the first ones, are you using them at all for your patients?
Well, yeah,
In the systole and diastole models?
yeah, ventricular systole.
Correct.
Yeah, ventricular systole. So they're still making the SLA models. The SLA models give you some notion of, in your mind's eye, of where the implant's going to be, and you can play with it. Unlike the engineering models, they can place the stent or the valve in different positions on the CT scan. But here you have the model in your hand, and you can get some notion of what the implant's going to be like. I think from our experience with the Harmony valve is it basically ends up where it ends up. You may want to do a distal implant and open it up into the LPA a little bit, let it slide back, but it basically, it's going to, if you pick the right patient, I can say without a doubt, and I think Eric and Mark would agree with this, the implantation is not the hardest part of this. The implantation is fairly straightforward. The most difficult part is picking the right patient because we were very limited to size. Now that these other sizes are available, I think that it's going to be open season on this population.
Excellent talk. I was going to ask you, follow up on this question. Simply putting a very compliant balloon in the right ventricular outflow tract to get the contour in the cath lab, usually because I don't pre-stent anymore on the Edwards valve something, and I will inflate the balloon like Amplas balloon, hook it up to a monitor, to up to 2 atmosphere, and then I will do an RV angiogram to see if it's completely occluding or not. Are we going too far about reconstructing the RVOT models? I mean, it has given pretty decent information. So I think progress is good.
Very interesting
But how
question.
far?
Yeah, so that's an important question. And because when these things become commercially available, we're not going to be able to do 3D modeling on every patient. It's just not going to happen. And the companies are looking at different ways of screening the patients to pick the devices. And I think what's going to ultimately be is they're going to avoid CT scans. And it seems as though ECG-gated MR studies give you much better resolution of the outflow tract, that you can then use those. If you want to use those to make a model, fine. But you can use those for your screening purposes and picking your devices. Because on a practical standpoint, you can't take the patients and have them go through these various studies. There's too much radiation, particularly for the kids, unless everybody has these low-dose CT scanners, to make it something that's really clinically available or applicable.
Do you mind if I ask a question as well? Z, your experience with the venous P valve, what are your impressions after, how many cases is it now? He's right behind you.
Yeah, the valve actually works very well. So indeed, it is rigid, especially when it's long. That's why now my preference is to go to the 2 or maximum 2.5 centimeter length the straight segment. Of course, it's 10 above and 10 below. So even the 20 is 40 millimeter long. So that's long. And the smaller the kid, the harder you will have time to get it from the femoral vein to the MPA. I did the first in man, or first in human, May 23rd, 2013. So 2 days ago was 5-year anniversary. Both patients are doing well. So far, we have done 200 cases in the pulmonic position, 60 in China for the Chinese FDA trial, which requested 2-year follow-up on all patients, and the data looks very good. There is endocarditis, couple of cases in China, so all valves have endocarditis, and 140 cases outside the Chinese trial, among them in the CE trial and many other compassionate cases. So the valve is very good. We only do MRI, and in the cath lab we do balloon sizing, as Zahid mentioned. You put a balloon in the MPA RV outflow tract and you inject in the RV, and that will give you the best information you need to choose the size. I like to do a cath before this, because simply the company has to fly these valves. So you don't want them to fly and they don't have the right size valve. So you prepare these, do diagnostic cath, get it out of the way, then order these valves and then do the procedure. The procedure is very simple and takes about an hour and a half. But it's a good valve.
One other question in the back.
Dr. Benson, so with these self-expanding valves, would you less worry about distortion and the coronary issues, or has that not been evaluated?
Yeah, also a good question, and it's really an engineering question. And that comes up in many of the discussions about implanting these valves in much smaller outflow tracts. So let's say that let's look at the Altera, for example. So the Altera is about 40 millimeters, and they want some compression, so or 42 millimeters. So they want the perimeter diameter to be, let's say, 38 or 37 millimeters. So you get compression at the two ends. So what if it's 35 millimeters or 32 millimeters? So there's a lot of compression of the device, and that's where the engineering FEA assessments become important, where they determine what the stresses are on the implants at various compressive cycles. And as it turns out, for the Harmony valve and for the Altera, from the engineering standpoint, they're very, very robust in terms of the fracture rate on the devices is very low at the ideal compression rate. Compression is, what the engineers call interference, to hold the implant in place in the outflow tract. So it's actually pretty good. It's pretty good.
All right, thank you very much, Lee. We're on time, so let's keep it up.
I think we have a couple of post questions just quickly, but let's
Okay.
give the round of applause. And we'll just take Lee's questions quickly, and then we'll move right on. Can you put up the next one, guys? There you go. Okay. Okay. Is there another one, or?
Oh, it's a typed one.
Oh, is this a typed one?
Yep. All right, should we keep going?
Give it another 60 seconds.
Should I start introducing Nathan in the meantime?